Endoscopic management of reflux. There are different endoscopic techniques used in management of vesicoureteric reflux. First is the classic sting technique. Subureteric Teflon injection, Odolin and Puri. 3.5 to 5 French needle is inserted with its bevel side up, approximately 2 to 3 mm distal to the ureteric orifice. The needle advances in the submucosal plane for 4 or to 5 mm. The goal is to raise the volcano-shaped mound with the urethral orifice located at the top. Double modification of a sting. The needle is inserted in the submucosal plane but within the intramural ureter. The characteristics of the ideal injectable material. This material does not exist. It's just what we seek in the available injectable materials till science invents the ideal material. It must be non-toxic, stable without migration to other organs, causes minimal local inflammation, become well encapsulated by normal fibrous tissue and fibrocytes, easy to inject, viscous enough to prevent leakage from puncture site, durable, meaning it maintains injected volume shape after normal interaction with the tissue. If someone finds this material, please call me. Different classifications of injectables used for endoscopic correction. Particulate versus degradable, autologous versus non-autologous. How does distant migration occurs in cases of injectable materials? First, injection causes disruption of small blood vessels. Thus, materials gain intravascular access, and particles less than 50 grams may bypass pulmonary vascular bed and reach systemic circulation. Second is the phagocytosis of injected particles. Materials less than 80 grams can undergo phagocytosis and be carried into the bloodstream. The outcomes of endoscopic correction. Classic sting has 80% success rate, while sting with the Doppler modification has 90 to 95 success rate. The goal of injectable agent is to buy time for kidney to mature. A recurrence of reflux later on life may not be clinically significant. The recommended follow-up after endoscopic injection. It is a must to continue the antibiotics for 3 months and follow up ultrasound and VCG at 3 months. Consider repeating the injection at 6 months after initial injection if persistent reflux. Open surgery. Recommended after second failed injection. No additional difficulty after deflux or macroplasty. It's variable after other materials. Material removed on block before open reimplant. Proper technique for standard subureteric transurethral injection sting. Therapy involves the following steps. First, emptying the bladder to 3/4 capacity so as not to displace the ureter laterally. Placement of the needle with the beveled side up into the posterior portion of the ureter. Visualization of the creation of the mound with initial injection of 0.1 to 0.2 millimeters of the material. Multiple injection sites implied there was difficulty in obtaining a proper mound in the correct plane, as well as increasing the possibility of leakage of injectable material. Kirsch et al. Reported improved results by modifying the standard technique by performing hydrodistension of the urethral orifice and injection into the submucosa of the urethral tongue. Before all, sterile urine is a must. Surgical techniques will be illustrated in the next video.